Welcome to this episode of the Clinical Podcast Series brought to you by the American Academy of Optometry Foundation. On today's episode, we will be discussing the article entitled Ocular Surface Disease in Patients with Atopic Dermatitis Treated with Dupilumab, a Prospective Case Control Study, published in the journal Cornea in February 2024. I'm Dr. Kelsy Steele, your host and the topical editor of the anterior segment disease care section, and I'm thrilled to be joined today by our topical expert of this episode, Dr. Sara Hitchman. Dr. Hitchman is an optometrist in the Department of Ophthalmology at University Hospitals Cleveland and serves as an assistant professor at the Case Western Reserve University School of Medicine, Department of Ophthalmology and Visual Sciences. Dr. Hitchman is the co-director of the Optometry Externship Program at University Hospitals and is a fellow of our academy. Thank you for being here today, Dr. Hitchman.
Yeah, thank you for having me. Glad to be here.
So let's start off with some definitions. Briefly, what is atopic dermatitis?
So atopic dermatitis is a chronic inflammatory skin disease that affects both children and adults.
What is dupilumab?
Dupilumab is a monoclonal antibody that inhibits interleukin-4 and interleukin-13 signaling. It is the first biologic approved for the treatment of atopic dermatitis for grades moderate or severe, and it isn't approved actually in children. It's given as a subcutaneous injection.
Are there known ocular manifestations of atopic dermatitis?
Absolutely. Atopic dermatitis can manifest as atopic keratoconjunctivitis, which sometimes can look like dry eye disease or really severe allergic conjunctivitis. Typically, hallmark signs would be thickening of the eyelids and maybe even telangiectatic vessels along the border of the lids. And then also, atopic dermatitis has been shown to be increased or linked to an increased risk of development of keratoconus.
Mm-hmm. Okay, so now that we've gotten some definitions out of the way, what was the purpose of the study that we're covering today?
So the purpose of the study was to evaluate the prevalence of dry eye disease in patients with atopic dermatitis who are treated with dupilumab, and the study was conducted over the course of 6 months.
What were the metrics that the investigators used to test their hypothesis?
So they used a variety of different dry eye tests to determine the development of dry eye disease. One, they used the OSDI, which is a symptom survey that patients fill out. It's 12 questions. And the questions are asking patients symptoms that they've experienced in the last 1 week's time. They used tear breakup time. The one thing they didn't specify was how they determined the tear breakup time, which was one question that I kind of came away from the study wondering about. They also used tear osmolarity testing and ocular surface staining. They graded that on the NEI scale. For staining, they used the Schirmer's 1 test, which is unanesthetized Schirmer's testing. They did do a routine of 30 minutes in between each test. Notably, the tear osmolarity test cannot have any type of eye drops in the eye for at least 30 minutes prior to the testing. So they did space all the tests by 30 minutes, which was probably good and better to, in an effort to have better, more accurate and reliable results. The order of the testing is very important for dry eye testing. You don't want to disturb the ocular surface or the tear film if that's the next test that you're going to be doing.
Right. Typically least invasive to most invasive is how that goes.
Absolutely.
So do you think this was a good study design? Would you have used anything differently? They kind of commented on using dry eye as kind of, dry eye testing as a surrogate for testing this metric. Would you have made any changes to the test that they did and the order?
Yeah, I think overall, the tests that they did were good, high tests that can give practitioners good information about what's going on. Again, the question that I came away with was, how did they determine the tear breakup time? At one of our offices, we have an Oculus keratograph, which
Yeah,
can
it's like if I
measure non-invasive tear breakup time. And I'm wondering if that's what they did, since that was the second test that they did, and that preceded testing for osmolarity. Possibly that's not known to us from the information in the study, but that would be one thing that I would recommend if you're testing tear breakup time first. Try to do non-invasive tear breakup time. So for individuals out in practice, sometimes that can be difficult to do. You might be doing some fluorescein staining to determine the tear breakup time, in which case you would want to do an assessment of the tear film, such as osmolarity or inflammadry first, and then later on, like you said, least invasive to most invasive, do some fluorescein staining and assess that. The other question that I had coming away from the study that I wasn't quite sure about, they did do Schirmer's 1 testing, which is unanesthetized. And they didn't say in the study whether or not they accounted for the fact that reflex tearing may occur over the first minute. They just stated that it was measured after 5 minutes of time. In our offices, in an effort to try to eliminate any potential reflex tearing that might occur just by the strip going in, we do the Schirmer's 2 test. So it is anesthetized, and then we dab out any remaining proparacaine and allow that to kind of settle out of the tear film so that that fluid volume does not interfere with the test.
Okay.
And then we also do the test over a course of 6 minutes. We measure at minute 1 and minute 6, and then we subtract 1 from 6 at the end. So it's still over the course of 5 minutes, which the Schirmer's 1 is over 5 minutes, but we do it in an effort to try to negate any potential reflex tearing that might skew our results.
Right. Yeah. So maybe
Those were the questions that I had about
okay.
the test was done.
A little bit more detail on the methods.
Yeah.
So what did they find overall?
So I'm going to just go over the statistically significant findings, and then I'll end with the non-statistically significant findings. So they did find that the prevalence of dry eye disease did worsen in individuals receiving Dupilumab for atopic dermatitis over the course of 6 months compared to the control group. They also found that the level of corneal staining was increased. There was no change in the control group. And they found that the Schirmer score was reduced over the course of 6 months compared to no change in the control group. Non-statistically significant changes, they noted that there was an increase in the OSDI symptom survey, but that was not statistically significant difference. The tear osmolarity, interestingly, had no difference from the baseline to the 6-month follow-up in both the treatment and the control group.
So when you deal with these patients, do you specifically educate, treat, or follow up with your patients with atopic dermatitis treated with this medication, like in a specific manner or different than you might otherwise with a dry eye patient?
Yeah, interestingly, this medication, Dupilumab, is not only approved for atopic dermatitis, it's also used for patients who may have moderate or severe asthma. However, we do know that atopic dermatitis, atopic dermatitis, if that is the reason that they're receiving the Dupilumab medication, conjunctivitis is more common in individuals using Dupilumab for atopic dermatitis than another reason. And so I do try to educate all of my patients with atopic dermatitis just in general, but anyone receiving Dupilumab, I do try to let them know conjunctivitis is a common side effect, but it is very treatable. I've had lots of patients with really good success in treating this condition that helped them to not have to come off of the medication that was working for their systemic disease.
Right.
I always recommend that they should be coming back if they're starting to notice symptoms. And I think that dermatology in general is pretty good about, asking patients receiving Dupilumab or other immunosuppressive medications about potential side effects that they might notice.
Right. Great point. So to wrap things up, should we as eye care professionals implement any changes in our care of patients?
Well, I think the big thing would be just educating them that if they are receiving dupilumab, this is common. The other thing that we try to do in our practice for patients with atopic dermatitis in general is screen them for keratoconus, whether they're receiving dupilumab or not. Um, because any potential um, increase in sustained eye rubbing may further increase that risk of keratoconus.
Right.
And that's something that we need to be ahead of, especially since we have an FDA-approved procedure to help limit potential long-term side effects of keratoconus. The other thing that I think that I liked about this study, and I would recommend to other individuals, is using the NEI scale for grading corneal staining. I personally find that to be very helpful. It is quadrant-specific grading in 5 quadrants. It's on a scale of 0 to 15. And I find that very helpful to look for, maybe changes in just one quadrant versus the other from one visit to the next. I do really like that option.
Great point with the keratoconus screening. We know that that's associated with patients with any kind of atopy. So good to keep that in the back of our mind, especially with, untreated patients or patients who have been not completely treated with whatever their medication protocol is. So we appreciate that. Thank you for your insights today, Dr. Hitchman. And thank you for listening or watching. We'll see you next time.
Thank you.